All right. Good evening, everyone. So I'd like to welcome you all to tonight's MSIG webinar, Textbook Injuries, where each speaker is going to share their expertise on a specific sport and identify the most common injury from that sport. My name is Aaron Lange. I am serving as the moderator for tonight's webinar. I'm a third-year medical student from Rocky Vista University, and I'm interested in PM&R, sports medicine. Grew up in Northern California and lived in Colorado for the last 8 years or so. And in my free time, I am a USA track and field elite running coach and a sports massage therapist. Tonight, it's an honor to have 3 AMSSM members serving on the speaker panel. We have Dr. Amadeus Mason, Dr. Monique Burton, and Dr. Adam Tenforde. The sports that we're presenting tonight are track and field, marathons, and acrobatics. After their presentations, I will serve as the moderator for a Q&A session. So please enter your questions in the chat anytime during the webinar, and I will read each question during our Q&A segment toward the end of the session. So now it's my pleasure to introduce our first speaker tonight, Dr. Amadeus Mason. Dr. Mason is an assistant professor in orthopedics and family medicine at Emory University School of Medicine. He completed his sports medicine fellowship at ASMI in Birmingham, Alabama. And he is a fellow of the American Academy of Family Practice and holds diplomas in International Olympic Committee and FIFA in sports medicine and soccer medicine. He's also an RMSK certification in musculoskeletal ultrasound. Dr. Mason serves as the medical director for USA Track and Field Championship events, the Atlanta Track Club's Elite Athlete Program, and Overtime Elite Basketball. He's also the director of Emory Sports Medicine's Running Medicine Program and is the physician of Georgia Tech track and field and cross-country teams. He has been a USA track and field team physician at the last 3 Olympics. So, Dr. Mason, you have the floor.
All right, let me go ahead and share the screen. Thank you, Aaron. Yeah, thank you. Today, I wanted to talk about some textbook injuries in track and field. This is a kind of a tough topic in that no disclosures here. It's a tough topic in that you'll have 3 or 4 day conferences that talk just about the injuries in track and field. And what I'm going to do is I'm just going to talk about the running side. Dr. Burton is going to talk about the field side because track and field are very different type of injuries and conversation. So the objectives here, I'm going to talk about how I got involved with the sport, talk a little bit about the biomechanics of running, and talk about the single most common injury, and then give some pointers on the exam skills and a brief talk about treatment and recovery, and trying to talk about injury prevention as well. All right, so how did I get involved with the sport? I'm a Jamaica native, so I had to either play soccer, run track and field, or play cricket. I was better at track and field than I was at the other two, so I ended up running in at my high school, Monroe College. It's a small school, but we had a very good track and field team, and I got injured as a high school athlete. but the injuries that I got did not prevent me from being able to be recruited into college. And so I was able to run at college at Princeton. I was a sprinter. I ran the 200 and the 400, but also I got injured in college as well. And when I got injured, these injuries allowed me to be interacting with and talking to sports medicine physicians, physical therapists, and it kind of got me thinking that this is something that I would like to do, trying to get other athletes who got injured back to their sports. My college coach was the track and field head coach for the LA 84 Olympics. And Coach Ellis was a huge influence on my life and was a great mentor for me. And as I was going through these injuries, getting rehabbed, and when I decided to go on to medical school, it was he who said that told me that I had to give back to the sport, and he was the one who directed me to start volunteering with USA Track and Field when I was in residency and when I in throughout fellowship, and that got me the experience and the exposure to start doing things with track and field. He was also president of USA Track and Field at the time, and so was able to get me connected. So that's how I got involved with the sport at this level. Talking about some exam skills to help you diagnose injury in the sport. Here, it's taking a look at the patient or the runner completely. You got to take a look at them from their pelvis to their toes. You need to remove their shoes, remove their socks, being able to see their feet appropriately. Having them in shorts is preferable so that you can get a really good look at the hips, knees, ankles. You look at them from the front and from the back, checking their alignment. Again, you're looking at hip, knee, ankle, and feet. If you can, being able to get some kind of gait analysis, seeing them walking, seeing them standing, if possible, seeing them running on a treadmill would be good. And you always want to be able to examine the running shoes. Get a history of the problem. So figure out what the whenever you're doing a physical exam or you're getting information from a patient, the biggest thing is getting your history. That's going to help you to get that appropriate diagnosis. A biomechanical assessment can be helpful, but you need to know what you're doing, and just being able to take a look at their gait and get an understanding of that can sometimes be enough. Sometimes you can do a site-specific evaluation where you go out and you do a running assessment, seeing them in their element and are running and seeing them with the shoes that they may use, whether that be spikes or running flats, so you can see what or if there are any problems that are arising as they're doing their dynamic activity. Talking about the biomechanics of the sport, running is not just walking fast. It is a different type of propulsion in that you do have the same 5 or 4 aspects of the gait cycle. The heel contact, mid stance, toe off, and mid swing. The difference is that in the mid swing area, you have a point where both feet are off the ground, and that's kind of the double float area. And depending on whether you are a sprinter, middle distance, or long distance runner, the mid-swing, the stance phase, and the way in which you transition from those different phases will vary. And the amount of time that you spend in that double float portion of the gait cycle varies and can be a help or a hindrance in your progressing forward. The single most common injury, I'm going to kind of do a little bit of a cop-out and give a broad category as opposed to a single specific injury. I think the single most common injury in runners is overuse. They end up doing too much, too soon, or make too many changes all at once. And they do that with too little rest. It is either they are changing their terrain, they change their changing their training patterns, etc., too quickly, or they start off running 10 100s or 10 150s when they really should be doing one or two and gradually building up. Injuries like tendinitis, this is an overuse injury. Most common location, patella tendon, Achilles tendon, and hamstring. The muscle strains, again, coming from overuse most commonly. Most common muscles that are strained are hamstring, the quadriceps, and the calf muscle. And then with bone, there's the bone stress injuries. The medial tibial stress syndrome, MTSS, sometimes called shin splints, is kind of it is a bone stress, but not quite a bone stress injury. It is more of an irritation of the periosteum and the musculature of the bone. But apophysitis, which you find in younger athletes who have open physes, is the bone stress injury that occurs there. And of course, stress reactions and stress fractures are the other bone stress injuries. And so these are the most common injuries that you will see in runners, and they all have that common denominator of being overuse in their origin. The brief talking about the treatment. The first thing that you have to do is get in and get evaluated. See somebody who has a good understanding of runners and what they do and don't need, and how to talk and evaluate a runner appropriately. Second thing is that as they come up with a treatment protocol, it's going to involve some kind of cross-training, doing other types of activity that allow them to still build on their training as well as build fitness, but are not activating or irritating the area that is injured. Appropriate gear. This is another facet where as you are doing your treatment and are trying to counsel on how to prevent injury, you want to make sure that they have the appropriate shoes, the appropriate clothing for the type of running and the situations that they will be running in. And then warming up and stretching. This is very controversial in that there have been a lot of studies, and none of the studies show clearly that stretching helps to prevent injury, but stretching and warming up appropriately can help to improve the flexibility and improve in turn the ability to perform and get through training and performances. And so in a kind of roundabout way is kind of helpful in preventing injury. And then finally, hydration and nutrition, making sure that there's appropriate pre-hydration, appropriate nutrition during the running events. And I'm quite sure that Dr. Tenforde will talk about some of that and mention some of that as he talks about marathon running. So in summary, kind of in quick, when you talk about running injuries, most of those running injuries are due to overuse. When you're doing your exam, shoes off, shorts on for the physical exam, and make sure that you're examine running shoes. And then with regards to injury treatment and prevention, you gotta encourage a good hydration and nutrition. And then most management of these injuries are conservative. You're not going to be doing a lot of intervention from a surgical standpoint. It's going to be things like physical therapy, using interventions like shockwave or debridement and PRP injections. Thank you. 10 minutes.
Thank you, Dr. Mason, for your presentation. So now it's my pleasure to introduce our second speaker, Dr. Monique Burton. So Dr. Burton is a clinical professor in the Department of Pediatrics and Orthopedics and Sports Medicine. She is a board-certified pediatrician with certification of added qualification in sports medicine. Dr. Burton completed her pediatric residency at Children's Hospital, Oakland, and a primary care sports medicine fellowship at UCLA. She's a medical director for the sports medicine program at Seattle Children's. Dr. Burton is the chair of USA Track and Field Sports Medicine and Science Committee and has been volunteer team physician for international teams since 2005. Including the 2024 Paris Olympic Games, the 2020 Tokyo Olympic Games, and the 2008 Beijing Olympic Games. She serves as the chair of AMSSM Diversity, Equity, and Inclusion Subcommittee and is on the board of the King County Play Equity Coalition. Dr. Burton was a collegiate gymnast at University of Pennsylvania and enjoys all aspects of physical activity and working together with her patients and athletes to create an individualized plan so they may reach their own unique physical activity, sports, and wellness goals. She also has a strong interest in equitable access to play and physical literacy. Outside of work, Dr. Burton loves spending time with her two daughters. She also enjoys partner acrobatics, yoga, and exploring various hobbies and baking. And now, Dr. Burton, you have the floor.
Thank you. So I have so many slides. I'm not going to do them all, but I can send them to Erin, I think, after so that you guys can have them. I'm really actually going to talk about throwing. So not to neglect our other events that are in the field, but each of them is, like Dr. Mason said, is kind of its own talk. And so there's a lot of cool things about throwing and it often gets like left out. So we'll talk about throwing. Maybe, let's see. Okay, no disclosures. So similar to Dr. Mason, my, well, actually not similar, sorry, but I've been involved in track and field for a while, but my story is that I was in my fellowship and I was training in an area where there was somebody locally who was working with track and field. And he said, hey, would you be interested in going on a trip with USA Track and Field? And although I was not a track and field athlete, it was actually one of my favorite sports. My sister did it, and it was a really big sport in my high school. And so actually before I started high school, we'd go to their state track meet because it was super cool. So got really involved as a fan at that point and maybe ran a little bit, it wasn't very good. And then, so I went to an international team right out of fellowship training, which felt very terrifying. And then was able to continue traveling and have been the chair of the sports medicine science committee since 2013, and have been fortunate enough to go to the Olympic Games in 2008, 20, and 24. And so here's what we're going to take a look at, just a little brief kind of review of a couple epidemiological things, but mostly one is just kind of focus on like the biomechanics. I'm going to skip over that, but track and field, oldest sport in modern Olympics, which I think I feel proud about since that's our sport. It's also known as athletics. The throwing events include the shot put, discus, hammer, and javelin. And they share some common features. So I'm going to move see my slides. Maybe. Okay, there we go. So some common features of the throwing event share is that there's a generation of this maximal force over this really short period of time. And that kinetic chain is used to generate the power from the lower extremities to deliver it in the upper extremities. But as you can imagine, that puts a really high stress on the tendons, muscles, ligaments, and joints. And there's a lot of repetitive motion. So that's certainly like one of the concerns with throwing events. The unique features are that there's different techniques for each event. There's different implements based sizes based on gender, and there's different body types. So here's just some example of like the various different body types. I think people often think of like very strong person, kind of bigger person thrower, and there's definitely like very lean and like long kind of throwers, body type. This is just to show you that in track and field, shot put had the highest proportion of throwing injuries, might be because that's one of the more common ones we see in high school. And then as far as injury location, ankle, the back, and then the upper extremity of the shoulder. So this is kind of an interesting thing just to know about throwing, just to go through the stages. So there's lots of different descriptions, and it's hard to find a uniform description of them, but I'm going to take you through kind of what they all have, and they all have an entry, a middle, and a delivery. So in the entry, that's kind of properly positioning yourself to throw. In the middle, you're building that force and momentum, and you're transferring the weight between your feet. And then in the end part of the throw, you're getting into that final position. You're developing that maximal force, and then you release the implement. And there's this really strong period called blocking, where basically the momentum that you developed is transferred into the implement to deliver it, hopefully as far as it can go. So blocking is a place where we often see a lot of injury because there's a sudden bracing or stopping and deceleration of forces, ideally to go into the implement. But as you can imagine, that also is transferring into the body to stop that force. So in shot put, I'm going to skip through that, but basically very old. You see shot putters in old photos. It's a metal ball at different sizes, depending if you're a man or a woman. And there's a throwing circle with a curved toe board, which you're not able to go past. There's a glide and a rotational technique, but they're both intended to build energy in the lower extremity and then create this kind of spring effect and deliver that into the shot put. So the grip is like really kind of this fascinating thing where you're placing your fingers on the base, but not in actually the palm of the hand. And then they place it underneath their jaw, press it into their neck, and then they throw from there. I think that's, to me, was important to know, because if in shot put we see finger injuries, and you kind of can understand why when you see that positioning. So as far as the glide technique, it's this preparation, a glide, delivery, and a recovery. There's no motion. But in the rotational phase, don't worry, I'm not going to go through this whole thing, but basically you're starting upright, you're leaning forward, they do a turn, and then they release it. So this is the glide technique. And then, I'm sorry, I skipped the language of that. So in the rotation, they do a rotation and they release. And so we'll see that. I don't think I have a video of this, but there's a starting stance, a rotation, then the delivery. And then, yeah, here's a rotational technique. And then discus. I think this often, like, people will think about it as like a frisbee, not a frisbee, a little hard metal object. The disc is different sizes for men and women, and it's a similar throwing circle. The grip, they put in their the non-throwing hand goes beneath the disc for support, and then their throwing hand, they place the implement and they kind of put the tips of their fingers over the top of it. And then they have, again, a stance, a turn, kind of a flight phase, and then a power phase, that blocking and that release. So here's an example of our Olympic and world champion. And then hammer. Hammer goes way back in time as well. It's a metal ball that's attached to a handle, different sizes for men and women. There's a throwing circle, and then they do this crazy amount of force where they spin around and deliver it. You grip the handle, and they often wear a protective glove to be able to make sure they don't get an injury from that. And again, there's a preliminary swinging phase, turning, and then the delivery. So here's an example of hammer throw. It's pretty impressive to watch. It's so much power. And then javelin. Javelin's a bit different than those ones. So this also a long time sport, metal tipped object. There's a really important kind of configuration of your grip. There's an approach, the legs cross over, they release, and there is, of course, that blocking before the release. That's where a lot of injuries occur in this event. So here's an example. Yeah, so you really have to deliver that into that, and you can't go past that line. So I, like Amadeus, was having a really hard time coming up with what is the one injury that we would talk about. And I think that one of the things that's important to just think about is that there's common injuries in these sports because they're generating a lot of force, and you have to have strength, flexibility, speed, balance, coordination, and then this explosive power. But there's also injuries that are distinct to each event within your throwing events. And there's not actually that much information out there about them. So I'm just going to do a little bit on the ones that I think are the most common. So shoulders are a really common one because why you're putting so much force into that shoulder to be able to deliver the implement. There's a lot of repetitive motion. All that energy is transmitted into the shoulder. They actually, if you look at throwers, you'll see some pretty significant adaptive changes. And so one of the things as an examiner is to make sure you're asking about the throwing arm, because when you're examining a thrower, they may look imbalanced, but that may be adaptive for their sport. They might notice that they have increased external rotation and decreased internal. They may have hypermobility in their joint capsule, and they might also have some increased translation of that humeral head. Common injuries are rotator cuff injuries, glenohumeral joint injuries, and some dysfunction within the scapulothoracic region. And just kind of briefly on the elbow, because this is another big one, especially in the javelin and kind of that feared, dreaded injury. Again, look at that position. It's pretty significant how much load they're putting on their elbow. And so because of all that load and that stress, an injury that we commonly see is a UCL injury. Similar to other types of throwing events, because of all that load, the UCL can experience a lot of force and then certainly tear as a result. Often what they see is some kind of initial micro trauma, and then it becomes an insufficiency and such that there's not enough stability and can go on to be more significant of an injury. And with that, you might see some ulnar nerve injury as well. I'm going to skip over wrist, and I want to make sure we leave time for questions. So I'm going to kind of wrap up. Just wanted to point out again, look at these fingers and how much motion goes into that finger and how much force you can imagine has been delivered when they're doing that. So do think about fingers and the possibilities of injuries there, recognizing that force. Yeah, those are crazy, how far they're bent back. And that's not an injury. That's just what it looks like. And then certainly there's also some injuries within your trunk, your spine, the thoracic spine, the lumbar spine, and then the hip as well, because there's all that force, right? You're taking, you're planting, and you're really pivoting into there. So, and knee. So I'm going to skip through these because I do want to make sure we have enough time for questions and I can answer more. But I think the kind of the take-home message of these injuries that happen in throwing events is that there's so much force that you're delivering into the body, into the implement. The throwers do a lot of the strength training here, so they can get injuries in that area as well. And then also just remembering that there may be that imbalance because of their sport, but that also can lead to some other trouble within their spine. So remembering that. Injury prevention, I think, is really important. So making sure that they've developed proper technique or working with a coach who's able to work with them on technique, certainly doing strength training based to help to provide the strength to generate those forces, but also flexibility because they need to be agile enough to get into those positions, and making sure that you have proper equipment so that they're able to be sized appropriately, especially for the younger population, and finding people who are familiar with track and field when they're doing their rehabilitation. So I will stop my sharing. Oh, I had to put that in there. Dr. Mason and I were in Paris together, and that was on our first day where we go and get to see the track, and which was very purple and fun.
Thank you, Dr. Burton, for your presentation on throwing. That was really fascinating. So now it is my pleasure to introduce our third speaker, Dr. Adam Tenforde. Dr. Tenforde is an associate professor in the Department of PM&R at Harvard Medical School. He is a director of running medicine at the Spalding National Running Center, and it's one of the only centers in the United States exclusively dedicated to the diagnosis and treatment of running-related injuries. Dr. Tenforde has the unique perspective of being both a doctor and a former professional runner who is an All-American at Stanford, where he contributed to 3 NCAA national team championships and later qualified for the US Olympic trials. Dr. Tenforde's research has focused on evaluation of biological and biomechanical risk factors for stress fractures and other running-related injuries. He's also investigating how to prevent injuries in athletes. Dr. Tenforde, you have the floor.
Well, thank you so much. It's hard to go after Dr. Burton, Dr. Mason. At the same time, I have an easier task when asked to describe marathon, where I'm going to focus primarily on the biomechanics of running and focus on tendinopathy. So in terms of conflicts of disclosure, these are my full disclosure, none are relevant for the talk. So I'm going to talk a little bit more on the biomechanics of running. I think Dr. Mason did a great job trying to provide a truncated version given all the other aspects that he covered. I'm going to get into a little bit more detail on a specific injury, Achilles tendinopathy, and talk a little more about how to evaluate and treat this injury. Again, a lot of this dovetails nicely with what Dr. Mason and Dr. Burton covered, which is you really want to find physicians that understand the individual sport and the demands. So why do I focus on running? A lot of it is based on what was shared during that introduction. I was very fortunate to be part of some great teams as a D1 athlete. I recognize though that I'm not the most talented in my family. My wife, who actually made an Olympic team, is the most talented in the 10,000 meter. But running the marathon has been something I've really enjoyed, and I enjoy taking care of runners of all levels. Yeah, it's a great sport. So I direct the Spalding National Running Center, and we focus a lot on the biomechanics of running-related injuries, which is what I'm going to go through given the task of focusing particularly on the marathon, which is covering 26.2 mile distance. So we really want to kind of think through the mechanics of running and recognize that running biomechanics are likely to change over the course of completing an endurance event. And so when we're performing these evaluations, we need to recognize that oftentimes biomechanics are being evaluated during the fresh state. And, more limited studies have looked at how biomechanics might change with fatigue or change with terrain, which is where we're using a lot of wearable sensors to better understand these changes and how we can inform injury management and prevention. So getting into the details for how to perform a gait evaluation, again, the gait evaluation can be a real extension of the physical exam. Totally agree with the prior speakers on the importance of getting a detailed history and recognizing that most injuries are multifactorial in nature. From specifics that are good to get in runners, understanding how someone looks when they perform a single leg squat, how they perform when they're asked to do a simple hop test, or even perform calf strength to fatigue, it can give you a better sense for their relative symmetry. And if you really break down the sport of running, it's a series of single leg squats, hops, and landings without falling down. If you have time, seeing how someone moves walking can actually give you some better details in terms of the biomechanics outside of the sport, because that represents how they're maintaining their mobility, and sometimes will cross over to ways that they're moving abnormally with running. Giving individuals adequate time to warm up and ensuring they feel comfortable running on a treadmill is really important prior to performing a gait evaluation. And then, similar to the previous talks, it's really important to have a systematic approach. So I'm going to kind of take you through the 4 main areas to look at: the foot and ankle, the knee, hip, and trunk, and how you can kind of break down those different movements to understanding possible biomechanical factors associated with marathon running related injuries. So first off, from the standpoint of the foot and ankle, there are a few factors to look at. The first is the foot progression angle. For example, you might see an asymmetry when viewing a runner in the coronal plane from behind the treadmill, where they may be toeing out on one side, and you have to then start to ask the question, well, if that's an asymmetric movement, is that related to an injury they're experiencing? Looking for the degree of inversion or eversion at the foot and ankle. Again, the whole concept of pronation versus supination, and how those are going to put different demands through the musculoskeletal system. For example, increased pronation has been associated with certain conditions such as medial tibial stress syndrome, or development of tibial bone stress injury. Crossover is another factor which really describes when the person is in the mid stance phase. Do you see the foot cross a plumb line that you would draw from the middle of the lumbar spine and pelvis down perpendicular to the ground? And crossover can sometimes represent weakness in the lumbopelvic region, where by not maintaining their gluteal strength or their pelvic stability, they oftentimes will have this crossover, although crossover can also happen at the foot and ankle. So breaking those movements down can be helpful to kind of look for asymmetries. Cadence is another factor which represents steps per minute. One common aspect we see with cadence is this concept of the magical number 180. That comes from the observations by the exercise physiologist Jack Daniels during the 1984 Olympics, where he was observing runners during the Olympics from the 800 meters to the 10,000 meter, and made the observation that 180 steps a minute seemed to be an optimal cadence across those events. So again, we need to recognize those numbers are associated with performance. And if someone has a lower step rate, increasing the step rate, thereby increasing the cadence, might be able to be an effective strategy around modifying the risk for certain injuries, such as bone stress injuries. We can also look at foot strike pattern, and really the key things to think about with this is that rear foot strike is a pretty common pattern in marathon runners. We've observed up to 95% of runners will strike with their heel. That's not necessarily a bad thing, but it is something associated with a higher rate of loading as compared to striking with a midfoot or a forefoot. So that graph on the far right represents that with the rear foot strike, you do get a higher rate of loading that's been associated with certain running related injuries such as plantar fasciitis. When we get to the knee, there are a couple of features to look at. In that far left panel, what we're looking for is the presence of a knee window. You can see on that top panel, there's no daylight during that mid stance phase. And sometimes you'll see an athlete will actually have chafing in their medial knee, and that can be a sign that their knees are rubbing together, and can be, again, another sign of instability in the lumbopelvic region or increased femoral adduction with internal rotation, oftentimes seen with the condition patellofemoral pain. So in the bottom panel would be the presence of a knee window. You can also see from this coronal view, from the posterior view, the presence of where the popliteal fossa is. When it's off the midline, that can also be signs of that internal rotation of the femur, changing where the popliteal fossa is in relationship. Sometimes there can be more subtle features that you'll see from the frontal plane in the coronal view of where the patella is. And again, the concept is that you sometimes will see these asymmetries of the position of the patella, or the patella is facing more inward, which can be associated with certain conditions causing anterior knee pain, such as patellofemoral pain. In the hip, there are a few features to look for. The first is the presence of hip adduction. So does the thigh come towards midline? The middle panel illustrates the concept of femoral adduction with a contralateral pelvic drop. So that right leg is in the mid stance phase, and you can see the left hip dropping. That again can be a sign of poor gluteal strength, particularly gluteus medius. The sagittal view is also a good one for looking for the presence of what we refer to as pelvic tilt. An anterior pelvic tilt can be a sign that individuals are not stabilizing the position of their pelvis, and that anterior tilt oftentimes is associated with a reduction in posterior chain activation of the gluteal muscles. Again, a factor that we oftentimes are trying to modify as we find that a number of runners are more anterior chain dominant, and we're trying to engage their posterior chains. So addressing pelvic tilt can be helpful. When we get into the trunk, it's worth recognizing there's fewer features here. The first would be trunk lean. This is a picture of my wife's teammate, Meb. You can see he's got a nice plumb line, forward lean. It's been suggested by Chris Powers, a 5 to 8 degree pelvic trunk lean can be helpful for posterior chain activation. So if you see a runner that looks more upright, like they're the road runner, that oftentimes is associated with, again, a reduction in posterior chain activation patterns. We can also look for the presence of coronal symmetry and drawing a plumb line, seeing whether you see symmetric arm carriage. Now, I'll point to this picture because I'm not trying to pick on my wife, but she's on the right. And she did a lot of her training on an indoor track where she found that she kind of developed a mean right hook. So she had a lot of asymmetries with her arm carriage. However, it's worth noting that this was at the Olympic trials where Elva Dreyer, who is seen on the left and has a more symmetric arm carriage compared to my wife, they both made the Olympic team. So we have to be careful how much we're trying to modify of someone's running mechanics, and recognizing that health and performance can be two different variables. But again, we're just looking in the trunk of some forward lean and keeping the arms relaxed, and oftentimes trying to avoid excessive crossover in midline. So I'm going to get into conditions, and I was asked to pick one injury that was most common. The one I'm going to focus on is Achilles tendinopathy, where it's been estimated that up to 52% of male runners will experience this injury over the course of their lifetime. And this is an injury that I personally experienced. Tendinopathy is defined as a failed healing response, which results in pain, stiffness, and loss of function. We have to recognize that when we're approaching this injury, as with most injuries, there's a general distrust of physicians. So we'll see in a lot of the runners we provide care for. So building their trust and helping them to understand that our goal is not to disqualify them from competing, but it's really to identify ways to effectively rehabilitate, to think through cross-training and all the things they can do to ensure that they get back to their full health and are able to perform at their highest level. The second is not looking at one element. The earlier comments regarding biomechanics, that's one aspect of evaluation of a runner. Aspects of nutrition and sleep and psychological stress, those are all important variables that can also contribute to injury. And really having a team-based approach is important for optimizing outcome. And again, if I were to develop a schematic, thinking about the runner at really the center of this equation and the role of the physician, but also the full athlete's entourage to optimizing the evaluation and treatment of an injury, and the goal to have everyone on the same page to ensure that you develop an effective program. So when getting into Achilles tendinopathy, a few features to look for: inspection, palpation, range of motion, and the strength and integrity of the Achilles tendon. With a tendinosis, which we oftentimes refer to as more of a disorganized collagen with very little inflammatory milieu, this tends to be a more thickened nodular tendon. With the Achilles tendon, there's a synovial sheath, the peritoneum, which surrounds the tendon, and sometimes you'll see some associated crepitus. Oftentimes, to evaluate this injury, just seeing how the individual performs when they do a single leg heel raise can be very helpful. The Thompson's test is a common tool that is described of whether someone has an obligatory plantar response when they are in a prone position and you squeeze the gastrocsoleus complex. The absence of a plantar response could be a sign of discontinuity of the Achilles tendon, suggesting a rupture. But really, you're not probably going to see that in someone who's walking into clinic with a more chronic indolent case of Achilles tendinopathy. The things I like to look for in addition to evaluating the tendon is seeing how the individual looks with a single leg squat. This can be very helpful for looking at their stability proximally and also getting a better sense for what they would look like if you were to do a biomechanical assessment running. There's actually been some pretty good reliability that a single leg squat oftentimes predicts someone's running mechanics. And you can look for elements at the hip of their stability. You can look at what also is happening at the foot and ankle. Does their foot seem to pronate excessively on one side, which could be a sign of weakness of the transverse and longitudinal arch of the foot? Do they have difficulty maintaining position of the foot? For example, does their heel lift off or their toes lift off to suggest a tight heel cord? And also looking for other elements of how they're positioning their foot and ankle during this process. With a calf raise, I like to joke there's the right way, the wrong way, and Adam's way of doing calf raises. So I'll have the individual perform a single leg calf raise. Common biomechanical errors that individuals will make is they'll roll to the outside of their foot. And as I like to joke, the goal is more on the eccentric phase of loading, so maintaining pressure of the ball of the foot as they go into the eccentric decline to load the tendon effectively. For imaging, let's recognize ultrasound can detect most cases of tendinopathy. It's a low-cost, portable, effective way to evaluate the Achilles tendon. X-rays can be helpful for looking for the presence of calcifications or determining if the individual has a Haglund's deformity, which would be increased bony growth over the posterior lateral heel. And MRI does have a role, but more in select cases or when you're trying to detect mimickers such as a calcaneal bone stress injury. For the management, really a lot of this comes down to developing an appropriate loading program. With an acute tear, you're going to be putting the person into a tall walking boot with a heel wedge, which is oftentimes gradually reduced to gradually lengthen the tendon after a period of immobilization and then structured rehabilitation. With the more chronic tendinopathies without a more discrete tear, it's really about getting them into physical therapy progression. The study that really led us to thinking about eccentric loading comes from Alfredson in 1998, and that's referred to as Alfredson protocol, which is demonstrated on the left. On the right illustrates the modification you make if someone has an insertional Achilles tendinopathy, where you don't want their heel to drop below the ground because they oftentimes will develop posterior ankle impingement and retrocalcaneal bursitis. The pain rating scale in the top right reflects Corinne Spivernackel's work of the green, yellow, red zone, which has been validated in the Achilles tendon for loading and keeping your pain below 5 out of 10. Spivernackel showed that over the first 6 weeks of rehabilitation, running can be safely done, keeping pain below 5. This has been further modified to recommendations for most activity to be done between 0 to 2 out of 10. And any activity that is in the 2 to 5 range to not occur more than once or twice a week. This can be applied, though, to other tendinopathies in the lower extremity. I do like to make a plug for other interventions. And as Dr. Mason mentioned in brief, shockwave therapy in combination with eccentric loading can be quite effective in the treatment of this condition based on a meta-analysis that we performed. It is worth recognizing, though, that the outcomes oftentimes are seen at 3 months, and that tendons remodel over 6 months or longer, very similar to the signs of bone stress injury. So we do need to caution the athletes around the load progression, load management strategies to ensure they do not get re-injured during that time of healing. And in summary, if we were thinking through the marathon, remember the biomechanics are important. The Achilles tendinopathy is a very common injury, and if you understand the key aspects from this talk, you can apply these to most tendinopathies that you treat. And our management really comes down to an appropriate diagnosis, a good history, physical exam, and developing a good exercise program with selective interventions at time to help with tendon healing. So thank you so much for your attention. I'll be on for the Q&A.
Thank you for your presentation, Dr. Tenforde. For our last presentation, it's my pleasure to reintroduce Dr. Monique Burton again. She's going to be discussing the sport of acrobatics.
Right. Oops. Sorry, I'm trying to share things and not go backwards, but so this is, I can be brief on this actually, so that we have a little bit of time, but I should clarify that I think partner acrobatics falls under the category of circus arts. And so it probably sounds really random, but it's because I participate in it. So my story is that my daughter started circus classes. As Erin mentioned in the beginning, I was a gymnast growing up. So my daughter started in circus classes. We have a really great circus school here in Seattle, Washington, that is very inclusive and very inspiring, and kind of anybody could do it. So they started classes there, kind of like the Mommy Me classes. And they were very smart. They had adult classes at the same time. And I was like, okay, that looks pretty cool. I'll go ahead and try that. So I started taking adult circus classes. COVID happened and everything shut down, and wasn't able to do the classes anymore, but I really missed it, missed that kind of like body movement. And then I started training partner acrobatics and done like small amount of performing. I'm going to say a tiny bit. So this is performing with my daughter. This is this is called duo trapeze, where you're on a still trapeze and you're doing something together. It's a really special moment to be able to share with her. And then these are not the greatest pictures, but this is with both of my daughters. And we did this acrobatic act. This is a partner acrobatic, but obviously like multiple people. And part of this is just to show you guys how much stress your body may take. And then this is like my only like real performance in partner acrobatics, and it was part of a benefit they asked us to do. And also kind of trying to show you just the amount of force that goes through your shoulders. And so just talking about circus arts, there's lots of different disciplines. And this is not even comprehensive, but if you kind of think there's some things we commonly think of are acrobatics, which might include what I was showing you, partner acrobatics, contortion, tumbling, and hand balancing, which often also includes some contortion. There's the aerial arts, which I think we often think of a lot. There's the fabric or the silks, as some people will refer to them. There's straps where you're holding on and you're wrapping your arm with, thinking of Greatest Showman. There's the lyra, there's trapeze that is still, and then you can perform all these like solo or double or triple or even more. There's equilibristics, which are things like rolling globe, unicycle, rollabola is what that's called, and then the tight wire, and then there's even more. And then object manipulation is another really popular category that includes like juggling and hoops and plate spinning, and which is here, and then Diablo, or we call it Diablo, but it's like Diabolo. And then this is, I just put this in here. This is me doing hands. Like, I'm glad there's not that many people, but you may watch this, but it's slightly embarrassing to show myself. But this is part of a contest that we were actually doing to try to hold it long. But the reason I showed this is just like how much he's experiencing a lot of stress. And then this is a lot of force in your shoulders. And actually your job is the flyer. So the base is the person holding. The flyer is a person in the air. And the job of the flyer is to be like a stick and not move. And the base is to keep the stick from falling. And so there's a lot of collaboration and coordination, and obviously a lot of trust. And there's a lot more types of activities you do in partner acrobatics, but we'll talk a little bit about like what comes up in circus artists. So there's actually obviously a lot of different injuries that come up, but shoulders are a pretty popular one just because of all the different apparatus or different disciplines. And so there's a lot of, since there are a lot of different disciplines, there's a lot of different types of injuries that can happen. But shoulder injuries were like 27.7% of injuries at the University of Arts in the Netherlands when they were doing a study over, actually during COVID. And if you think about it, circus artists have to have a lot of stability and strength, but they often have hypermobility and have some atraumatic instability. So because of that hypermobility, that allows the joint to move a lot more, and you also have to have a lot of stability. So it just is a lot of demands on the shoulder. So just kind of quickly, I'm going to go through like the shoulder. So we know we have our bony anatomy, and probably you hear this repeated a lot, but the shoulder anatomy is, as far as the bones don't have a lot of stability in the joint. So you have your scapula, your clavicle, and your humerus, and then the joint is made up here, and you often hear that analogy of the golf ball and the golf tee, and there's not a lot of stability from from the bone. And then you also have multiple joints. You have your acromioclavicular joint, you have your glenohumeral joint, and your sternoclavicular joint over here. And then you also have scapular thoracic motion, and that's an important thing to think about, especially in people who are doing a lot of stability and motion through their shoulder. Oops. Oh, no. Okay. Here's a glenohumeral joint, and I think this is a really important one to keep in mind when you're thinking about shoulder injuries. There's the fibrous capsule, there's the labrum, and all of that is to help to add stability to the joint that is lacking from the bony stability. Okay, here we go. Your muscles that make up your shoulder joint are your rotator cuff muscles. We think about our supraspinatus, our infraspinatus, and our infraspinatus. This is a posterior view. So your supraspinatus, your infraspinatus, and your teres minor, and then your subscapularis, which are going to give that stability since you don't have as much from the bones. So when you're testing for shoulder strength, we have our classic supraspinatus test, or the empty can test, and that allows us to test abduction as well. We have our infraspinatus test where we're checking, our external rotation test where we're checking the strength and stability of your infraspinatus and your teres minor. This is done by external rotation when the elbow is held at 90 degrees of flexion. Then we have our subscapularis test, or the liftoff test, where you're rotating behind your back and you're trying to press against the examiner. And then our provocative maneuvers. So these are important ones when you're evaluating the shoulder. NEARS is when we're checking, we will be able to find out if there's any signs of impingement. Impingement occurs when you have some inflammation in your rotator cuff tendons, as well as in that space where there may be some inflammation of the bursa. So when you're moving the patient's arm, they're relaxing, you're moving their arm above their head. And if you get some narrowing in that space, that causes pain. There's also subacromial impingement, where There's also the Hawkins Kennedy test where you're again doing a subacromial impingement type of test. You're in a kind of this wing position, I think of it, and that's how I remember Hawkins. And you're elevating the humeral head into the joint, and that causes some irritation. And then O'Brien's test is testing for labrum, and that's having the arm just slightly in the midline of, in front of you in the midline of the body. You do the test with resistance by pressing downward with the thumb down and then the thumb up, and that allows you to determine if there's any irritation and potential labral pathology. This is one of the things that I think, sometimes I think it ends up getting skipped in the shoulder exam because we're so focused on the injury, but in a circus art, it's definitely an important thing to like look at, and that's that instability. And so you'll find often that if you're checking for inferior instability, you're pulling down the arm, you're looking for a sulcus sign, so a little divot just underneath the acromion there, and that helps you to determine if there's any downward instability. It's positive if you see a centimeter or more displacement. And then anterior, I didn't put that in there, but anterior posterior instability is also really important to check. And you can do that by like kind of grasping upon the humeral head and trying to shift it forward and backward. And that lets you know if there's instability, and certainly comparing it to the other side to see if that's part of who they are or if that's unique to them. And then finally, this apprehension test where I like to do it laying down, where you're doing external rotation and you're seeing if there's a sensation of instability that gives them a kind of creepy kind of yucky feeling. And then if you place some pressure on the humeral head and do that again, that gives some stability, and that would be indicative of some instability. So now I'll just say this real briefly. So the treatment is physical therapy, but I think the really important thing about a circus artist is that there's some prehab that they're doing, ongoing rehabilitation, and finding a physical therapist who really understands the sports of circus, performance arts, gymnastics, or cheer, somebody who's going to understand the unique demands on their body, because there's some real nuanced type of strengthening that you do. And that's really important for somebody, and also finding people who are tolerant of that type of mobility, because some people tend to think it's a little bit crazy. And so finding somebody who really understands the activity, modifying the activity to allow for recovery. I found this myself to be really important, that, you know, and many athletes tend to just push, but in this activity like circus, when you are doing an activity and you have a body part, especially the shoulder that is injured, you tend to start to shut down, and then you're not able to do skills. And I think that that's one of the key things I know I've learned from my experience, is when you start not being able to make some of your skills and you've had some pain, especially in the shoulder, it might not be actually that you're having trouble with the skill. It might be that your body's not allowing you to do something that can actually be painful for it. And then supportive care. And what I mean by that is certainly like, if there's a lot of soreness, you may consider anti-inflammatories or ice or other things like that. So, all right. That didn't leave a lot of time for questions, but hopefully caught us up a little, and happy to stay on a little bit longer as well. Thank you.
Thank you, Dr. Burton, for your presentation on acrobatics. I'd now like to open up the rest of this session for some question and answer. I'm going to start with a question in the chat for you guys. So Mohammed asked, under what circumstances running can be painless, but walking is painful? Pain location is pretibial, the distal half of the lower leg. MRI ruled out a BSI. Patient's flexibility is good. Only finding is knee recurvatum, slightly LLD, old painless calcaneal spur. Anyone have any insight on that?
I think that is that's something that very specific need to dial into, would want to get at least a little bit better information about what do they mean by it's painful running, but it's painless running, but painful walking. There's a couple more things that we need to get. At least I think I would want to get an understanding of to be able to give an answer to that. I think maybe talking to us offline might be a better way to dial into that more discreetly.
I agree with Dr. Mason. And I think the other thing to keep in mind too is that walking mechanics and running mechanics are different. As Dr. Mason pointed out, you know, the absence of a time in which one foot is in contact with the ground is the very definition of running, which is why there are penalties if you're race walking, if both feet leave the ground at the same time. And it would be common to strike with your heel. That is normal walking mechanics, whereas running mechanics, people can have variations in foot strike pattern and very different body weight demands through their lower extremity.
Thank you for that insight. Mohammed, if you have any other questions about that, feel free to speak up. Otherwise, anyone else, feel free to post any questions in the chat or ask any questions you might have. It looks like we have a question from Brevin. He asks, can a ganglion cyst appear similar to an insertional Achilles tendinopathy?
I think you're describing two distinct entities. You need to try to establish, you know, again, a ganglion cyst is typically going to be a fluid that's coming from a joint. Whereas if you're talking about insertional Achilles tendinopathy, you can develop pre-calcaneal or retrocalcaneal bursitis, but that's going to be different than a ganglion cyst. If you've got someone as skilled as Dr. Mason in ultrasound with those additional qualifications, you can sometimes distinguish the presence of a ganglion and whether you can follow that to the tibiotalar subtalar joint recess as opposed to a bursitis, which tends to be a little bit more localized. I don't know, Dr. Burton, Dr. Mason, any additional thoughts in terms of the key determinants?
No, I would agree. Two separate entities, and just knowing the history and getting the physical exam would help you to determine which is which.
All right, thank you. So next, looks like we have a question. So from Chris, he asks, how or when did you all learn MSK ultrasound in your training? And do you have any recommendations on someone interested?
Well, I didn't say Amadeus should talk, but I will say if you do a fellowship, you'll learn it now. But when I was doing my fellowship, actually, it was not a part of our fellowship training. And I work in a pediatric environment. And I'm thankful for Amadeus on our trips because my experience is very limited because of when I went through my training. So it's just part of what you do now as your sports medicine fellowship. But people like me who did it a while ago have to learn it in other ways. But there's lots of opportunities.
Yeah, when I was training, the ultrasounds were as large as the examination rooms. We did not have the MSK ultrasound. That's something that I ended up learning over time. And yes, Dr. Burton said, it is mandatory a part of your training. And it's also, as family medicine residency, ACGME just mandated that they have to have point of care ultrasound, which includes MSK ultrasound as part of their residency training. So you guys should be getting that in residency, if not in fellowship.
All right. All right. Any other questions from anyone before we wrap up here?
Do you want, there's one in the chat that I could just answer really quickly about, can the panel talk about how they were able to get opportunities to become involved in larger roles in sports medicine?
Yeah.
I think that, like, you know, I guess what my recommendation would be is that, like, find the sports that you feel passionately about, if that was the one that you did, or if it was one that you just really find interesting. And, you know, get to know, like, if there's local events and volunteer, high schools, or like things that come into the area, reach out to like the medical directors of those, and just spend some time getting involved in knowing people. And that helps you to build those connections. There is a lot of that, of building connections and getting that experience. The other way that you can get involved as you go down the road is that through the USOPC, so the US Olympic and Paralympic Committee, has opportunities to do some rotations within their Olympic training centers. And then that can give you exposure and connections with people to allow you to get to know sports. But I'd say the number one recommendation I have is find sports you feel strongly about, because you're going to spend a lot of time with them and you want to really like it. And also, don't get discouraged, because there's just only so many availability options. And there may be people who are already kind of in those places, but that always changes. And so don't get discouraged, find other ways to be involved. And yeah, and you know, don't feel shy about reaching out to people. And even if they tell you no, then find somebody else. And over time, it will happen.
Yeah, I would agree and reiterate what Monique was saying, in that volunteer, because I know that Adam didn't just start to be the person at the Boston Marathon. He first started volunteering and was there and was there and was there, and that he ran the marathon. He was around doing stuff that he wanted. I started volunteering at track and field events, and so it is find something that you like, and if you don't like it, that's fine too. Volunteer. That's the way that you get that exposure and get the experience. You may not know that you like it until you volunteer. So just make yourself available.
Yeah, I totally agree. A lot of it is about building the trust of the athletes, and you know, spending time and helping people to understand that you're a resource. That's really helped me to build the practice I have in the Boston area, and anywhere from the recreation to the elites. They understand there's the same urgency to get better.
Great. Thank you for sharing that. Let's see. Looks like we have another question from Vincent. He's asking, do you feel like PM&R trained sports medicine physicians have different opportunities than someone in peds or family medicine or EM or IM?
Well, this is a complicated question in some ways. I'd say no, but sort of yes. There's just there's a little bit of controversy going on right now around like some of the professional sports. And that could change by the time you're finished with your training. I strongly recommend you choose a specialty that speaks to you the most, right? Because I mean, at the end of the day, like, I chose peds because I love being around kids and working with kids, and my sports training allows me to work with everyone. But my heart and my home is peds, and that's where I spend my daily practice aside from USA Track and Field. And you want to love that. And so I think you find the one that you enjoy the most, because that will always be the choice that feels best. And like, you know, if there's some sports that don't feel like that kind of sideline coverage is what they want, then perhaps that's okay. Like, because maybe there's still going to be many opportunities to be involved. And I would definitely not choose it on like one sport, choosing to not include certain professions, if that makes sense.
And I would go a little bit different from Dr. Burton and said, yeah, of course there are different opportunities, because as a pediatrician, there's going to be a certain bent that you have. As a family medicine physician, it's going to be a certain bent that I have. As a physical medicine and rehab physician, there's going to be a certain bent that you have, and a certain innate skill set that you're coming in there with. So the opportunities will be different based on what you are liking and what you're exposed to. But the training and the competency that you have is no different, because you are a sports medicine physician. But yeah, the opportunities are going to kind of be different based on your training and what you found and what you liked and didn't like within your training and your base specialty.
I think, just to add to this, you have to think about the fact that the desire to do sports medicine, that's an additional fellowship year, and you're going to be spending a large portion of your residency training, whether it's pediatrics, family medicine, emergency medicine, internal medicine, or physical medicine rehabilitation, taking care of a diverse population. The most important thing is you care about the patients you take care of. That is the absolute most critical thing, because you're not supposed to be selectively just saying, hey, at the end of the road, I'm going to be so excited to take care of these active individuals. You need to be thinking about, how do you advocate for each person in front of you? And a decision on choosing PM&R over family, over peds, over internal medicine, over family medicine, that's a load of crap. If you're choosing one just because you think you're going to be able to cherry pick a certain sports practice at the end of the day, that's the wrong reason to choose a residency program. Choose what you're passionate about, and remember that every patient in front of you is the most important patient you're taking care of in that moment. And if you do that and you follow that as your North Star, you're going to be a great sports medicine physician.
Yeah, I just have to chime in there then and say, like, I absolutely agree. I mean, and you find super cool things that you get to do that you're drawn towards. I mean, I think we all probably have little, yes, you get to do some of these cool things and working with these elite athletes, but I mean, the most of my time I'm in my clinic seeing, musculoskeletal injuries in kids. I actually also see kids who don't move, because I want to help every kid to have that opportunity to move. So yeah, I feel like you tend to have a gut feeling drawn towards something and follow that. And there's different kind of I guess vibes to each specialty, and find what fits you the best and where you feel your heart pulling towards. And I really believe in that. I think you'll find the place that you feel is the best fit for you.
Thank you for sharing all that insight. Do we have any other questions from anyone before we finish up? So Chris is asking about the consensus on the use of NSAIDs for managing pain through training.
Well, I would say that that's a very broad and loaded question. It's all about how and why you're having pain and why you're having to manage it and why it's occurring during training. Depending on what the answers are to those three questions, I would say that you can use NSAIDs for the treatment of, or part of your treatment tools with an injury that somebody has, but I'd be a little bit hesitant to say that NSAIDs should be used to help you manage pain of training, because there are a number of different issues with that statement.
Yeah, and I think, the more we learn about the use of non-steroidal anti-inflammatory medications and the conditions, it really comes down to ensuring you build trust with the athlete so you can have an appropriate risk-benefit discussion and actually understand the injury you're managing. So, for example, the evidence for non-steroidal anti-inflammatory medications for management of tendinopathy is quite lacking, because for the most part, it's not thought to be an inflammatory process. And if you have a marathon runner who's using NSAIDs day of event, they're at risk for issues including dehydration, acute kidney injury, or even rhabdomyolysis. So, again, those aren't always the more nuanced discussions that individuals are having with their physicians. So it's, as Dr. Mason pointed to, you really need to understand how the athlete is using the medication for safe use.
Thank you for that. Any other questions? Probably wrap up here soon. All right, so before we conclude tonight's webinar, I just want to encourage everyone to join next Tuesday, October 15th, 8:30 p.m. Eastern Time again, for the AMSSM Journal Club. There's going to be 3 presentations on articles from the top 120 articles every sports medicine fellow should be familiar with. We're also going to continue our MSIG webinar in this textbook injury series. It's going to be on wrestling, boxing, martial arts, and weightlifting. And it will be featuring Dr. Aaron Monceau, Dr. Michael Kelly, Dr. Bryant Walrod, and Dr. Mark Lavalle. On behalf of all the members in attendance tonight, I'd like to really acknowledge our speaker panel and thank you all for your outstanding presentations. And I'd like to thank everyone that's attending here tonight for the MSIG webinar. And it was my pleasure serving as the moderator tonight. All right, so that concludes our tonight's webinar. Thank you.
Thank you.